You also want to be starting to think about reversible causes. So you want to be thinking about your 4Hs and your 4Ts. And I like, when I'm leading an arrest, I like to say this out loud, and sort of make the team aware that we're doing this. It gives other team members a couple of tasks to do as well, doesn't it? You know, if you want to do a fluid challenge, or if you want to make sure that there's a temperature being routinely done or something like that. In terms of the 4Hs, first H that we have is hypoxia. What sort of arrests are they going to be? Well, predominantly things like asthma, COPD patients, branching into things like airway obstructions. What are we going to do for that? Well, going to be ventilating these patients anyway, ensuring that they have good advanced airways, so stepping up through your OPs, NPs, I-gels to tracheal intubation, making sure that there's good air entry, that you're ventilating well, and having a look at your CO2 monitoring as you go along. You're going to want to make sure that there's sort of gold standard airway management going on there. Matt, should we just go one for one?
So hypovolemia is next. Probably those are the two most important features, I think, to be honest. So hypovolemia, generally, we talked about some obvious causes like trauma and things where you've got an obvious fluid loss. But there's the other things that Joe mentioned, sort of distributive. Can you say that word for me?
Distributive.
Thank you. Shock. I.e. things like sepsis, and sometimes even things like heart failure and the dialysis patients. So basically what you want to do there is key is make sure you're controlling any bleeding, preventing any further fluid loss, and giving either fluid or blood products as appropriate to help. The
next one would be an electrolyte abnormality, so hyperkalemia. These are the sort of things that in an arrest situation you can get from taking a quick VBG. Most likely patients that these are going to be in, probably dialysis patients.
Your renal patients.
Renal failure, chronic kidney disease, patients who are on significant amounts of nephrotoxic drugs to be thinking about. You also want to be thinking about other important metabolic issues, hypoglycemia. So get a sugar, whether that's going to come back on your VBG, or actually, whether you need to do a BM. Diabetic patients who may have arrested for this reason, really, really important and easily reversible.
Yeah. Finally, the final H, hypothermia.
Yep.
I quite like hypothermia. And I think, again, this is one of the key issues on ILS, is what determines hypothermia.
Yeah.
A temperature of 35.5 is not hypothermic.
Yeah.
That is basically...
It's quite cold though for me.
It's quite cold. But it's not going to be significant enough to cause an arrest. And generally, when you're talking about a hypothermic arrest, it's a patient with a temperature at least below 30, normally below 28. And typically, the UK isn't cold enough. The sea isn't cold enough, and most hypoxic arrests are sort of Arctic Circle type places.
Hypothermic?
Hypothermic arrests. Sort of Arctic Circle, Norway, other places.
Other places outside of Cornwall.
My geography is failing me.
So I would say maybe the Scandinavian countries, maybe Iceland, Manchester.
Yeah, Manchester. The key there is you basically want to rewarm the patient, but you also want to remove any cold clothes.
How do you go about rewarming? Just out of curiosity, and what's sort of your protocol for that? Is it warm fluids? Is it bear hugging? What's the sort of protocol?
Depends how cold they are. So most patients you can get away with just cutting off the cold clothes and putting some warm blankets on.
Okay.
Bear huggers are great. They do vasodilate you peripherally, vasodilate your skin, so you do drop your blood pressure a little bit. Warmed fluids aren't always warm enough to warm you up, but they do prevent further heat loss.
Right. Okay.
But the severe hypothermic patients, you're going to be doing things like lavages, where you can do bladder lavages. We put warmed fluid into body cavities, basically.
Right. Okay.
Peritoneal lavage or bladder lavage. That's right at the end of the.
Yeah, that's intense, isn't it?
Right.
So T's.
T's.
Yeah. So it's my go, isn't it? So toxins is something to think about. Not necessarily the first on the list, but it depends on your presentation. So if you've got a young patient who's had a cardiac arrest in a nightclub, it's going to be one of the first things that's going to be up on your radar. But things that you can do at the bedside, checking for any paraphernalia, getting a collateral history, checking for signs of drug misuse, looking on the notes. and or sort of checking pupils and things like that. But don't forget that toxins doesn't necessarily mean recreational drug use, and actually can refer to accidental overdoses, or particularly also if patients are on medications that have got a really narrow therapeutic index. So I don't know, something that always comes to mind is stuff like lithium or something like that. But it might not be a purposeful toxin ingestion. So just thinking about those really, and thinking about appropriate blood work and or reversal agents if there is a need for that. So a classic one is opiate overdose, thinking about giving naloxone, and I think we'll give that quite freely to patients if we're unsure if they've ingested something, because there's minimal harm to be gained to be sort of received by it, isn't there?
I mean, the other category while we're talking about naloxone is iatrogenic. So if we've administered some morphine, actually they've got a fentanyl patch as well, or there are lots of opiates at home. It does happen.
Yes.
Patients are coming with it's difficult to control pain.
Yeah.
We might have lots of opiates, either appropriately or inappropriately, and that can certainly be a cause to be aware of. T number 2, thrombosis is probably
that's probably the most
most common.
Yeah.
Whether that's a pulmonary embolism or whether that's a myocardial infarction. Again, we mentioned thrombolysis with PE earlier. You have to have a reasonable index of suspicion, and that's going to be from a collateral history or possibly from evidence from an echo. But you certainly can thrombolyse. It's an option to be discussed with the team.
So next T, so we've done toxins, we've done thrombosis. So tension pneumothorax would be something to think about. A clear presentation to be thinking about if you've got central trauma, whether that's blunt or penetrating. Usually we think about penetrating trauma, but it can also, again, be iatrogenic from causing barotrauma from hyperventilation from the bag, or in patients who have got significant respiratory disease. So commonly we think about our COPD patients, our asthmatic patients. The way in which we would assess for this is we would be asking the patient on the airway. We don't get patients to ventilate here in the trust. The practitioner on the airway to ask them how it's feeling, how the vents are feeling. Often it can start to feel quite stiff, quite difficult to ventilate. We can just auscultate the chest and look at chest rise and fall. And management-wise, if you don't have the skills, they do say to think about needle thoracocentesis. But the reality is that, and as I see Matt's face twitching because of his dislike of that procedure, the reality is that you want to be going for a finger thoracostomy and or insertion of chest drain if you need to.
So finger thoracostomy is the way forward. Just find your little safety triangle. Cut a little hole, sort of fifth intercostal space in the mid-axillary line. I mean, I say little hole, big hole if they're arrested. Several centimetres, just through the chest. Put your finger in or some McGill forceps. You'll go through the pleura quite easily with a firm wrist. Just open up the scissors once you're through there. Open up the McGills. You will easily open up the pleura. And if you put your finger in to maintain that hole in the pleura, you'll feel and hear air coming out. You might get some blood as well, that's okay. And most importantly, you'll feel when the lung's up. So you'll feel the lung touch your gloved finger. The issue with needle thoracostomy in lots of patients in the UK, the needle doesn't go far enough.
Absolutely.
Through the adipose to get into the lung in the first place. And when it has gone through, often they'll kink as well.
Yeah, and easily occlude just from any sort of foreign matter as well. So
finger thoracostomy is best. And final T is tamponade. I did momentarily forget.
I forgot whose go it was, that's my excuse.
So cardiac tamponade, again, difficult to diagnose. You're going to be thinking about your history. So if you're in a cardiothoracic centre and the patient's recently had a cabbage or some sort of open heart surgery, then that's going to be a lot higher on your list than if they haven't. We can put an echo probe on. We'll talk a little bit about that a bit later on. Treatment wise here, you're going to be putting a needle into the chest. I remember Rob Taylor telling me on the ILS course that he used to put, when he was like an SHO, it was almost routine management for him to put a needle in the chest in case there was a tamponade, and he said he always got blood, but he had no idea how far the needle was going.
Oh my goodness! Yeah.
So he was going straight to the heart.
Yeah.
But nowadays, with the advent of ultrasound, if you're suddenly in hospital, then you're going to be doing these under ultrasound guidance.
Yeah. Matt, what are your thoughts on IV access and or other sites?
So access is obviously key for you to be able to give medications and drugs, although, as we mentioned earlier, they're not as high priority, so your CPR and defib remain the priority. But if you've got lots of hands, which you will do at an arrest in hospital, peripheral IV access is fine. So a cannula is fine. We used to, when I was training, we always used to sort of say, it has to be a green in an arrest. And I think that's kind of gone out, because actually it doesn't have to be a green. Any access will do. These patients are shut down, you're going to struggle to get a really big line in. Make sure that you're flushing all your drugs with 20 mils of saline is another key bit. And if you're in an arm, certainly elevate the limb as best you can, just to ensure that you get good flow into the heart.
I think that's particularly amiodarone.
Yeah.
It's better to be in a kind of larger site if you can, but flushing, because it's so toxic, isn't it? So it's good to get that really good flush.
The other method to be aware of is IO, interosseous. These are generally for patients where you can't get IV access. So typically we have 2 goes to try and get IV access. If you can't get it, then you're going to get the IO out. Ideally, it's a slight sort of contrary here. So ideally you want an IO in the humeral head, because it has a better flow rate to the heart. The reality is, having an IO in that area, when you've probably got a defib nearby, you've got an anaesthetist, probably an ODP, you've got several people on doing airway stuff. Having an IO up there as well is often impractical. An IO in the tibia is okay.
Not sternal then?
Not sternal, no. We don't do that anymore. We're not in the military. And you can give anything down it. You can give all your resus drugs, all your fluids. You can't take blood off it, so that's one of the things that we talk about. You can get a very small sample of blood, and that's basically just enough to run a blood sugar. You will have to go to the biochemistry lab and explain to them that it's an interosseous sample. Don't put it through an actual gas machine, because you'll break the gas machine and irritate the entire department. Okay. He speaks from practice.
Think about just one last thing, I guess, that's building in the literature, building in practice, is use of point of care ultrasound. Yeah. And Matt, I guess you will know a bit more about this, really, because I don't use point of care ultrasound in the GP surgery.
No,
in my rest. No.
So yeah, as Joe was saying, it's becoming more and more common. So echo and ultrasound, it's really useful to look for, or to aid sort of diagnosing certain conditions, tamponade being one of them, and pneumothorax being the other sort of big one that we use it for. And the other key, actually, that I use in my practice is actually when you're doing a rhythm check and you're pausing for sort of 5 seconds or so, is putting the echo probe on the heart and going, actually, this heart isn't moving. This is true asystole. Yeah. This isn't a pseudo PEA or anything. This is the heart is not pumping at all. And actually, that's really powerful to see, and for the team to recognise, actually, this heart isn't doing anything. And sometimes when you put the echo probe on in an early VF or VT or even a PEA, and you can see that there's the old sort of twitch of the heart muscle, we kind of go, actually, we've got, maybe we'll go a bit further, but actually when you see nothing at all, that's really quite powerful.
And I guess it's a good thing to use alongside declining CO2, alongside your rhythm, whether that's asystole or not, to actually allow you to prognosticate this patient and make a shared decision with your colleagues and or family if they're present. So it's a good way of collecting information to allow you to make that decision.
Exactly. I mean, should we just talk briefly about stopping? As we mentioned earlier, the rise of TEPs has meant that we're doing less and less of inappropriate resuscitations. However, there are a few patients that slip through the net. And so I remember last week I had a lady in her late 80s who was from a nursing home with dementia and very poor sort of baseline, who came in cardiac arrest. And actually, what is in that patient's best interest? Maintenance of dignity. So really, what you want to be able to do is quickly exclude any reversible cause. As Joe was saying, when you're team leading, it's good to talk through the 4Hs and 4Ts. And then what you often will do, if you're of the thinking that actually this resuscitation is going to be futile, you verbalise that to your team. So you say, what we've got here is a elderly lady or a frail lady who's been in whatever rhythm for a certain period of time. I think the likelihood of survival is very low. The likelihood of surviving with a good neurological outcome is even lower. We've excluded any reversible cause. We have true asystole on the echo probe. I think we should stop. Does anybody disagree? And then you just go around each team member, and if anybody disagrees, then you discuss it there and go forward.
Yeah.
Generally, most people are of the thinking, if you've been doing a resus for a while, that actually dignity and and everything else is the key.
I think just a good communication skills and team resource management is crucial there, and communication both with the team and with the family, and then a good debrief afterwards to sort of go through that sort of hot debrief to talk about why that decision was made, and any comfortable or uncomfortable feelings that kind of come up from that. On the other side of the spectrum, which is what we want to talk about, is getting a ROSK, so a return of spontaneous circulation. Hurrah! When do we know it's going to happen? We can get an inkling towards ROSK with certain things, can't we? So a sharp spike in CO2 levels is allegedly associated with a impending ROSK, but really important to emphasise, a sharp spike in ROSK, a sharp spike in CO2 rather, should not be an indicator for you to stop and do a pulse check or anything like that. What that suggests is that there's a metabolic change. It doesn't suggest that you've actually got your patient back yet. So note it and consider it for your next rhythm check, but don't change your practice if you see that. It means that you're doing good work, and you should keep going doing that good work. A true return of spontaneous circulation is actually suggested by a rhythm that's compatible with life, clearly, a central pulse, and patients may start coughing, gagging, trying to pull the tube out. It's completely dependent on their cerebration, I think, at that point in time. Particularly, I tend to see those mostly in patients who've had a very small downtime.
Yes.
When there is a potential ROSK, it is then appropriate to stop compressions and check for signs of life. I mean, if your patient's trying to take the eye gel out, it's appropriate for you to check for a pulse. What do we do immediately after? What's your go-to in terms of you've noticed ROSK?
Yeah, so then I would go and put the kettle on. Yeah, I'd make a round of tea, maybe some champagne.
Celebratory champers.
No, we have to start with an ABCDE approach. Yeah, and again, you've got ROSK. That's a good thing. Yeah. We can all agree. But actually, this patient remains very high risk. They may remain very unwell. Yeah. You have to go through your A3 properly, optimising their physiology as best you can. Yeah. And then you need to consider destination. You know, is this patient going to intensive care? Are they going to coronary care? Are they going to the cath lab? Modern day practice, certainly where I work, is that actually these patients will go wherever they're going. They'll go via CT. Okay. That's the CT of their head to get a degree of how hypoxic their head is, you know, at the early stage, and it just helps prognosticate that patient.
Yeah, that's interesting.
If they go, you know, resus to CT to intensive care, and the report comes through that actually there's a catastrophic hypoxic brain injury, then your mentality might switch in intensive care to actually this patient probably isn't going to survive, or if they do survive, they have a poor outcome. Should we consider things like organ donation? It might just change your thinking
to a more palliative,
And equally on the flip side, if they've got a really good brain, then you'll be encouraged by that. Actually, you should go for sort of full bells and whistles.
We've gone over, we've had a bit of an overview, we've done some CPR and defib, and our thoughts on that. We've talked about shockable and non-shockable rhythms. We've talked about reversible causes with the 4 H's, 4 T's. We've had a little bit of a chat about access, ultrasound, when to stop and how to stop, and also what to do and which particular champagne to buy when you get a return of spontaneous circulation. And I would recommend a rosé champagne.